I want to welcome you all to the Patient Attribution and Activation VLC. So I'm AJ. I've been in contact with a lot of you through email. I'm the project manager here at the Safety Net Advancement Center at Arizona State University, and I'll be helping you throughout these sessions along with the whole Starling team who we're happy to be partnering with throughout this whole collaborative. So just a few logistic things before we get started. If you have your green speaker lit up green on the top of your screen, could you please click that and make sure that it's white? We have some feedback issues with that once in a while, so I just want to make sure we don't encounter anything like that. Also, make sure to keep your audio on mute if you're not speaking, just another reason to avoid some feedback. We're very excited to be working with you guys throughout this collaborative. We hope we can provide you all with some great information for your organizations, and we're looking forward to learning from you all as well. So with that, I'm going to let Andy from Starling take it over.
Great. Good morning, and my name is Andrew Principe with Starling Advisors, and we're excited to get this initiative, this particular learning collaborative started because we think it's going to be an interesting exploration together in the importance of various attribution and activation models on our ability to participate in value-based contracting. For the first time, I'm actually broadcasting live from the Arizona State University downtown campus. Normally we do this remotely, so I'm excited to be here. And I'm just going to give you a little bit of background on myself and the firm, and then we'll dive directly into the meeting. Your faculty for this learning collaborative is made up of three of the employees at Starling Advisors, myself, Amanda Stangus, and Samantha Jones, and throughout the course of the 6 sessions you'll be hearing from each of those folks. We've provided you our contact information here, and you will have access to these materials so that should you have any questions or comments as we go through the material, you're able to reach us and ask us any questions or engage with us in any way. We are a national consulting firm. We're very happy to be partnered with Arizona State University College of Health Solutions, as well as the Safety Net Advancement Center, and very grateful to the Robert Wood Johnson Foundation for their financial support for this initiative. We have worked throughout the country with safety net providers, specifically on issues of better aligning essentially the initiatives within safety net organizations with the overall desire of the state and federal government to reform healthcare through the lens of new value-based purchasing initiatives. This 6-session learning collaborative will focus on the topic of patient attribution and activation, and we're going to go through a series of learning collaborative topics, starting today with an introduction to the topics of patient attribution and activation. Next week, we'll be discussing a case study which is on effectively using patient attribution to prepare to manage total cost of care. And we'll be giving you some materials for you to work with within your group to discuss how you might go about actually putting some of these learnings into action. In our 3rd session, we'll be discussing patient attribution and activation best practices. And after our 3rd session, we'll be looking to schedule a 30-minute meeting with you folks in order that we can begin the process of preparing you to make your final presentation, which will occur during session 6. Session 4 will focus on technology, data, and workflow requirements for successful attribution and activation. Session 5 on effective patient communication and its role in attribution and activation. And finally, in session 6, you'll be reporting back to us on your group projects, which we'll discuss in greater detail later in the collaborative. Just a couple of quick notes. This session may go as long as 2 hours, but most of the sessions are scheduled for 90 minutes. The final session, session 6, because each of the groups we want to give each of the groups enough time to report out, will also be scheduled for about 2 hours. So please make note of that when blocking your schedules for the future sessions. The other thing before I dive into today's discussion is I want to make sure folks feel free to interact with us. In today's session, you're each going to be introducing yourselves, and it's likely we won't necessarily be calling on anyone throughout the presentation of the material. But in future sessions, we'd like to try to drive a certain level of interactivity with the group, and may pose questions to the group, may call on you to answer those questions. However, we would also encourage any questions or comments that you have in line with the presentation. Probably the most efficient way to get a question to us is to use the chat window and send either to everyone or to the presenters. And what we'll do is attempt to answer those questions or comments in line with the presentation material. You can also feel free to kind of pipe up on the phone. We'd be happy to have your feedback. That might just be a little more challenging. Today's discussion, we're going to first learn about one another. We think it's really important that you have a general sense of who's on the phone call here, so that we can really use this as an opportunity to learn together and potentially develop relationships that help us address the challenges that we'll all face in dealing with value-based reimbursement models, and specifically patient attribution and activation. We want to define patient attribution and activation in the Learning Collaborative early enough that we have a good common working understanding of these models. And then I'll be talking about how these models fit within various value-based payment models. And then lastly, we'll be talking about some specific use cases. Today's session is going to be divided basically between you folks presenting to us so that we get to know each other, and then us giving you some foundational information. There are 8 organizations on the conference call. I believe all of them are represented. And we asked you to put together a very brief introduction to your organization. What I'm going to do now is I'm going to turn it to the first group and ask that you spend about 3 minutes introducing your organization. Give us a little background. I will advance the slides because otherwise it would be challenging if we had to turn it to each of you. So please just prompt me as you're presenting to advance your slides appropriately in line with your presentation. And as I mentioned, if you could keep it to about 3 minutes, I think that would be helpful, because there are quite a few of you, and we want to get to the rest of the educational content. With that, do we have a representative from Cherry Health on the phone?
Yes. Can you hear me? This is Kayla.
Hi, yes, I can.
Hi, perfect. Okay, so my name is Kayla Doyle. I'm LMSW, and I work for Cherry Health. I'm the Director of Integration. Cherry Health is a federally qualified health center. We've been around since 1988, and we've grown quite a bit in that time. So we are located in Grand Rapids, Michigan, is where our main site is, but we have sites in Kent County, Berry County, Eaton County, Montcalm County, and along the lakeshore of Michigan as well, if we count our employee assistance programs. We serve probably more towards 70,000 patients at this time. We merged with another organization, 2 other organizations actually, in 2011, so that about doubled our size and more than doubled our mental health services. So at this time, we provide primary medical care, we provide behavioral health services, vision care, dental care, psychiatry, case management, prisoner reentry programs on the east side of the state, and most of our patients are Medicaid, Medicare, or uninsured. Next slide, please. Oh, that's me. So I'm the only one on the call at this time. I hope to have more people on the call next time. Director of Integration basically means that I'm in charge of getting everybody to talk to each other and play nice in the sandbox and take care of our patients' health needs as a whole instead of dividing everybody up into silos. We don't want to talk about medical issues, behavioral health issues. We want to talk about chronic health issues or just health issues in general. Okay, next slide. So I hope to learn about strategies for engaging staff and providing integrated care. Sometimes it's hard to get people understanding what that means. It's kind of a nebulous term that can mean a lot of different things. We also are always trying to get our patients more engaged in their healthcare, so we're not just telling them what to do. We want them to tell us what they need because they are the experts of their own health and what's going on with them. And I'm always interested in hearing best practices from others that are on this call, so I'm looking forward to participating.
Great. Thank you so much and welcome.
Thank you.
Next up, we have the Chickasaw Nation Department of Health. Do we have someone on the line?
Hi, yes, this is Amber Wilson. How are you today?
I'm good, thank you.
Good. So I'm the only one on the call this morning as well, but our project was we implemented a software known as MIDAS to help us improve quality outcomes and assist us with patient acuity empanelment. So next slide, please. The next few slides are actually just pictures of our organization and our tribal health boundaries. So we have a medical center here in Ada, Oklahoma. We're licensed for 72 inpatient beds, and that is the far top left. And then the other pictures are pictures of our satellite clinics that offer more primary care type facilities, and we have 3 additional ones of those. Next slide. These are our boundaries. So we are a tribal health facility, which means we have affiliation with the Indian Health Service, but we are compacted, so we're a tribal health facility, and this is a depiction of our 13 counties within our Chickasaw Nation boundaries. Next slide. Just mission and vision, I won't read that to you, but overall, we just want to be, focused on prevention, even though we're in healthcare and make money by people being in, seeking our care. We definitely want to focus everything on outpatient and preventative and keep the use of our acute care facility down to improve the outcomes for our patients. Next slide. Again, we were originally an Indian Health Service facility, and in 1994 we compacted to become a tribally operated facility. We provide direct primary care service to any federally recognized Native American, licensed for 72 beds, but predominantly our outpatient volume is where we see the most of our visits, and we had over 600,000 outpatient visits in 2015, and that rose in 2016 as well. Next slide. These are our team members who have assisted with our grant work. I'm the project director, and then we have our clinical and financial leader, as well as great support from our Department of Epidemiology, Research, and Public Health. Next slide. And what I hoped to learn from this collaborative, we are really trying to use our software and different things to establish patient acuity and panels. So just the logic and contributing factors others have seen success with to assign patient acuity to panels, and how others use this information to provide improved patient flow and ultimately, of course, quality of care, and then how best to balance the requirements of these national measures, patient needs, the various documentation requirements, all still while improving patient care and outcomes, and then to add to that, managing the costs associated with all of that. And I think that concludes what I have today. Thank you.
Thank you so much. Next up is the Community Care Partnership of Maine. Is someone on the line?
Good morning. My name is Teresa Knowles. I'm the Chief Quality Officer at Community Care Partnership of Maine. Our first slide, just to sort of introduce who we are. We started as one federally qualified health center in 2013 as an ACO, and over the past couple of years have grown. So we're now made up of 8 federally qualified health centers across the state, from the northernmost part of Maine all the way to the southern tip. And we also have 3 community-based hospitals as well. Our focus primarily as an ACO is really on the quadruple aim, which we're all pretty much familiar with. Really trying to give outstanding quality care to our patients, reduce cost, engage patients in their experience and hopefully improve that experience, as well as taking care of our providers and staff. Next slide. So the team will be made up primarily of myself. We also have 2 performance improvement coaches who are actively working with all members of the ACO to improve care, particularly on the quality side, as well as workflow and processes within the clinic. They're primarily responsible for all of the training needs that would take place in the respective organizations. And we also have a data analyst or a clinical informaticist, Rhonda, who will be doing a lot of work with the practices on the reporting tools that we have, as well as working with our EMR vendors to get discrete fields for reporting and allowing us to do a better job with taking care of our patients. Next slide. So what we hope to learn from the collaborative is just sort of best practices, how those of you on the call are using the data that they get to better take care of our patients and, through the attribution model, particularly if you're doing anything uniquely with the data to care manage or do more population health, what that might look like. And then also using the data from specifically the Medicare Shared Savings Program to look at costs and how we do that at the individual level and how we do that at the aggregate level. So really just trying to learn from all of you who are doing this work as well.
Excellent. Thank you so much. Next up is Community Health Center of Yavapai. I hope I've said that correct. Is someone with us?
You did, yes. This is Kevin Goss. Can you hear me okay?
I can, yeah.
All right. So it sounds like we're one of the smaller organizations based on what the previous folks have said. We are, as you can see in the slide, we're an F2HC, Yavapai County, Arizona. We've been around for about 16 years as a partnership between the county government and Prescott Free Clinic, which is a nonprofit organization that was originally operating a free clinic separate from the county, but then joined with the county about 16 years ago. We have 3 full-time health centers providing the full array of primary care services, mental health, dental, and we're getting close to 14,000 patients a year and about 40,000 visits per year. Next slide, please. I am the business manager here. I do most of the contracting with the health plans, with outside vendors. I help with policies, with program planning, implementation, and evaluation. I'm the only person from our organization on the call this morning. Also on our team is Lynn Goglin. She's a registered nurse. She oversees our care coordination and quality improvement programs. And Tracy Pitlikowski is our finance manager, who will be the financial leader for the project. Next slide, please. And 3 of the things we hope to learn from the collaborative are how to better activate our patients to seek preventive medical and dental care, how to better integrate effective case management and tracking systems into our EHR, and how to determine the cost benefits of moving staff into different positions and or adding staff in an attempt to maximize our value-based payment opportunities. And that's it.
Dallas-Fort Worth Hospital Council Education. Is somebody with us from that organization? Last call for the Dallas-Fort Worth Hospital Council Education and Research Foundation. Is anyone on the phone? Okay, well, we'll circle back with them. Dental Center, is there somebody on the line?
Yes, my name is Ariel Franco, and I'm with the Gary and Mary West Senior Dental Center. So we're really brand new, and we also work small. So we started operations in June 1st, and what's unique about us is that we're a dental clinic that's located within a senior wellness center. And so at the Senior Wellness Center, low-income seniors have access to meals 365 days a week, two times a day. And what some of our volunteers were noticing, and actually our CEO and dental director, Dr. Becerra, was that many of the seniors were unable to eat the meals because of the status of their oral health. And so with the help of Gary and Mary West, they constructed the Senior Dental Center, and we just received our license as a community health clinic in June. And so what's really unique about our model is that we provide everything in the same location. So the seniors many times are already on site for meals and the other wellness services that are offered at the Senior Wellness Center. We also have care coordination that helps them through the process. And so they start with a comprehensive geriatric assessment. From there, they move on to an oral health education class with our registered dental hygienist who completes a basic screening survey to look into their mouth. And that helps us triage seniors into our dental care and make sure that we're able to kind of consider the whole person before they start getting their care. And so we do provide a sliding scale fee, so many of the seniors fall below 100% of the federal poverty level, and so they pay $10 per procedure, or if they have Denti-Cal, which is California State Medicaid, then that will cover some procedures, but the reimbursement is very limited and it doesn't cover everything. Next slide, please. So I'm Ariel. I'm the grants manager, but we're a small administrative team, so it's myself. We have a program coordinator and our CEO and dental director on the administrative side. Everyone else is clinical dental staff. So I help with pretty much everything in terms of program implementation, and I have a background in care coordination systems. Next slide, please. And so we really want to see how others are using best practices, as many of others have said, to engage patients. We've had a really low no-show rate, which is great because we're located on site, but what we're noticing is that there's a lot of complicating factors in terms of mental health and homelessness and things like that are contributing to patients seeking more appointments than they potentially need, and also having difficulty kind of following an oral health regimen. And so we're looking at ways to engage patients in those and ensure that when they come back for their recall visits 6 months later that they're able to maintain their oral health status that we're working to restore. We'd also like to see how we can incorporate our value-based care into billing and reimbursement systems, because currently we're receiving much less in reimbursement than what it's taking to provide the care. That's it.
Thank you very much, and welcome.
Thank you.
Next up is First Choice Health Centers. Do we have a representative from that organization?
Yes. Good morning. Or yes, it's good morning. It's good afternoon for me where I'm at, but it's actually morning where you're at.
Yes, yes.
Okay, I'm Theodoro Anderson Diaz. I'm from First Choice Health Centers. First Choice is a FQHC. We see approximately 19,000 people, mainly all low income. We are scattered throughout 10 locations, and we provide a wide range of services, including primary care, BH, both mental health and substance abuse, oral health, women's health, optometry, podiatry, and pediatrics. We've been around as of 1996. However, behavioral health really came into the fold of the center back in 2014. So I've been at First Choice for the past 4 years. Actually, February is my anniversary month, and we pretty much have doubled our size in terms of population served as it relates to behavioral health. We're currently wanting to engage in really creating this whole perspective of comprehensive health, pretty much what other colleagues have mentioned before me, of really looking at the individual in a holistic fashion. Can you go to the next slide? I'm the only person right now on this phone call, and the two other individuals that we had originally had identified, one has already moved on and the other one is in the process of moving on. So we're in the process of identifying other project members to come join me. And in terms of our questions, I've become much more clear now that this particular learning endeavor will look at patient attribution and activation. And other than what's there on the slide, basically what we'd like to be able to do is to look at the best use of acuity levels. We're currently undergoing a practice transformation project in which we're trying to create acuity levels across the center. And we'd like to see how we can do that and best be able to develop integrated care. Also, we want to discover how incentive-based initiatives that we currently have with the providers that are production-based, how are these going to be impacted by the pending changes to the ACA, whether they reform it or whether they do away with it completely? How is value-based payment going to impact incentive-based strategies that centers might be applying with their specific providers? So those are things that we're doing and that we'd like to be able to get from this project. Also, some of the things that we're currently been doing in terms of integration, we've been actually implementing strategies to tackle issues of integration related to chronic care management. So in 2016, we actually implemented an integrated project with diabetic patients in which we saw an improvement, particularly within the implementation group of indicators when we compared it to the rest of the center in terms of the control group. So we'd definitely like to build upon that experience, and we're happy to be part of this initiative.
Great. Well, welcome and thank you, and congratulations on 4 years.
Thank you. Well, you're welcome.
Last up is the Worcester County Health Department. Do we have someone on the line?
Yes, we're here.
Great.
The Worcester County Health Department is, we've been around a while. We have a very robust behavioral health program, and that's kind of what we're, primarily what we're representing here. We have a very active school-based mental health program. We've been in the schools, all the public schools in the county for, I think, about 25 years now. We also do adult treatment. We're the only provider of psychiatry in our county. We operate our behavioral health services across 5 different locations. We have mental health addictions. We have psychiatric rehabilitation. We have targeted case management, all kind of wrapped up under one integrated unit. So we try to very much be on the forefront of integration. We're using telemedicine, telepsychiatry, and things like that. So we're, again, trying to be very much on the forefront, despite that we're in a pretty rural part of the state. We serve, just in our behavioral health program, at any given year, just over 2,000 clients on average. And I think that's about it. You know, you can go ahead and advance. So my name is Mike Trader. I'm a clinical social worker. We have also with us Julie Rain, who is one of our other clinical social workers, and we're behavioral health managers here overseeing our mental health and addiction services. And Lauren Sala, who's here, is our practice administrator, who's kind of deals with all of the money stuff and the billing stuff with us. And you can go ahead and advance to the next slide there. This is kind of what we're looking for. We're really looking towards a value-based payment model, and we want to make sure that we are as prepared as possible for that, making sure that we're, again, the majority of our services are fee-for-service, so we want to make sure we're able to remain financially sustainable in that world. We want to understand the value-based payment model and how the payments will be calculated. We're not really sure kind of what to expect. We've been involved with meaningful use and PQRS measures the last couple of years. We're kind of wondering how that's going to intersect and how that's going to kind of play out. And we also deal with a whole lot of folks with comorbid disorders and very chronic mental health and addictions issues. And we're kind of looking at how to measure outcomes and kind of how that's going to work out in this new payment model, and how we make sure that we're continuing to serve them in a good way, and how they're even going to be protected to to some extent in the new payment model. That's kind of what we're interested in doing. Thank you for having us.
Excellent. Well, thank you for being with us this morning. I hope you folks, got a good sense of who else is on the line. We think it's exciting to be able to bring together organizations that have such a desire and an interest to study these topics together. We hope that you'll find the material very valuable, but also, over the course of time, potentially developing relationships with other folks who might be facing some of the same challenges as yourself. Now begins the portion of today's discussion where we're going to give you some background and basic information about these two topics. And I'm going to start with the definition of attribution. Before I do that, I want to just tell a quick story that I think kind of gets to the heart of the shift that we're all probably experiencing, maybe some at different levels, maybe some of us on the phone. I heard a couple of people say they were involved in a shared savings program, have tackled some of these challenges head on, and others might just be kind of seeing them slowly coming down the line towards your organization. But my very first consulting assignment when I was a young consultant back in the early 2000s, I walked into the office of the CEO of a federally qualified health center who had printed out 7 large stacks of paper for me, upon which listed the names of all of the patients assigned by each of the 7 managed care plans that she was contracted with. And naively, I assumed my job was going to be figuring out how to help the organization best tackle the healthcare needs of those folks. And instead, what she asked me to do was find a way to get those patients off of her lists. Certainly, as we have experienced in the past, the assignment of patients to our organizations by managed care entities or other payers can be a somewhat frustrating experience if those patients are not patients that have ever necessarily set foot inside our organization. And yet, one of the key challenges and shifts going forward is that an attributed population to our organization is essentially going to be one of the bedrock mechanisms by which payment is determined should we enter into a variety of new payment methodologies. And so the discussion over the course of my first year working with that organization was, given our current payment model and some of the incentives available to us, it certainly makes sense to correctly clean up these lists. But if our payment model shifted and if we instead were being incentivized with monthly care coordination type payments or payments at risk for the quality of care delivered to this population, our thinking about how to approach those 7 lists of patients would certainly change. Another quick story that I think kind of sets some of what, helps us understand some of what's at stake. An organization recently entered into the Medicare Shared Savings Program as well as into some contracts with Medicaid managed care organizations that provided some fairly rich incentives for managing the population health of an attributed patient population. This organization felt they were well equipped to address those challenges based on data and reports that they had pulled out of their EHR system over the last several years that showed them being an awfully effective manager of population health issues related to chronic diseases, in particular diabetes. They were very surprised, however, at the end of the performance year to find that they had missed all of their incentive targets, not because they were ineffective at managing those chronic diseases in the patients who had been into their facilities and under their care, but because they had a very different perspective as to how the final calculations would be done and didn't factor in the large number of patients who the plan had expected to be under their care and were not actually engaging with their clinicians. So those two stories kind of set the backdrop for why attribution and patient activation are important as we discuss a shift to value-based reimbursement. Just a reminder, please send us any questions over chat or feel free to just simply ask over the phone. So we're going to work towards a definition of patient attribution. And this ultimately answers or helps answer the question under a value-based payment methodology, who are our patients? Increasingly, patients are assigned to providers or to a health system by payers. This patient is then connected to that healthcare system or provider, and that provider takes responsibility for care for that patient. That's how it's intended, essentially, to work. It's not drastically different than maybe kind of the gatekeeper model we saw in the HMO world, with some very different expectations in terms of quality and outcomes, which we'll be discussing throughout the course of this learning collaborative. Value-based payment models, generally speaking, with very limited exceptions, really do require the ability to link direct accountability for an individual patient or population of patients to an individual provider or group of providers that are working together. And by grouping these patients by provider, it allows payers to evaluate things like the total cost of care and clinical outcomes in a given area. So to better define attribution, attribution defines how health plans or others determine which provider is responsible for a patient's care. Sometimes you'll hear the term assignment being used, and a formal definition from Milliman. Milliman is one of the principal actuaries that works with a variety of states throughout the country on their Medicaid program. Attribution is assigning a provider or providers who will be held accountable for a member based on an analysis of that member's claims data or claim data. The attributed provider is deemed responsible for the patient's cost and quality of care, regardless of which other providers actually deliver the services. So as the HMO world kind of defined the gatekeeper, in this emerging world of value-based reimbursement, we tend to think of the attributed provider as the quarterback, the one that's responsible for kind of calling plays and seeing that they get executed properly. Who uses or defines attribution? Well, attribution is a concept that you're going to see emerge really anytime you're having a conversation around alternative payment or value-based payment models for your patients. So accountable care organization models always have a methodology for determining the attributed population of patients. Patient-centered medical home initiatives that might have some upside payments for achieving principles of the patient-centered medical home model will focus on which patients are in essence impaneled or assigned to a given practice. And health plans and government payer contracts that award payment based on things like pay for performance, the achievement of shared savings, or other types of risk-based contracting rely on making a discrete assignment of patients. You can't calculate, for example, the savings against a target unless both the provider and the payer of care mutually agree which population of patients you're looking at. There's a couple different ways that we're going to examine that attribution models are used. And we think that they're all important because they represent kind of the set of skills that we think your organization will need to hone over time as you become increasingly exposed to value-based payment methodologies. The first is probably the most commonly understood, the one we've been discussing most explicitly, which is payers using an attribution methodology to identify the value-based relationships with providers and provider practices. So being able to make the claim that the payer believes that a certain provider is the one most likely to be responsible for the outcomes and costs that a patient achieves. Another model, though, would be about simply using administrative data to attribute a patient when they have not previously chosen a provider or PCP. We're actually pretty familiar with this model, maybe in our own experience as a beneficiary of an insurance product, of receiving an insurance card with a primary care physician's name on it that maybe we have no previous relationship. And one of the things, particularly in the Medicaid world, one of the promises that Medicaid managed care organizations make to state government is we're going to get every patient in panel to a primary care physician. And in doing so, they may be using some type of auto-assignment methodology to make that linkage. Understanding how that works could have significant implications on our practice. A third way is to use is when attribution is used to identify a strategy to engage patients who are in the population but not previously seen. This was the approach I thought I would be helping to build when I was presented with those 7 lists, which is kind of a systematic analysis of the patients that an organization sees versus the patient that a payer wished they were capable of seeing on their behalf, and then doing something about it. And the doing something about it is what we'll discuss later as kind of patient activation or engagement. And the last attribution is used to support care system development. It allows us to see which services are attributed to a patient and identify ways to include those services in a care model. So we would use attribution data as well as potentially other data sources to study a population, an assigned population, and come to some conclusions about how to most effectively deliver care to that population. We might want to look at information about the type of setting that population lives in. For example, are they largely homebound, or do they have access to certain facilities or care options? We may look at the attribution data to figure out what our staffing models might need to be to properly address the healthcare needs of a given population. So attribution data is actually rather rich and interesting, and can allow us a bunch of capabilities, and we'll be discussing some of those capabilities today. Just a note, and we'll get to this in more detail at the end, I am going to be assigning you a case study, and our case study, which you'll be reading and then coming next week, or I'm sorry, in 2 weeks, our next session, prepared to discuss, we'll actually look at some real live attribution model data and give you an opportunity to kind of weigh in on which of these methods you would use and how you would go about doing that. I want to start our kind of deeper dive into various existing attribution models by saying that these models are likely to evolve over time. And for those of you who are in the Medicare Shared Savings Program, we're going to take a deeper look at that model because it's been one that's really been worked on pretty aggressively over the course of the last 7 or 8 years. And it's not perfect by any stretch, but given the number of iterations and revisions that it's undergone, it really does give us a lens through which to look at a variety of the issues that arise when you start talking about attribution. It's important also to understand that not every attribution model will be the same. An individual payer really does have the right to craft their attribution model however really they see fit to support the goals that they desire. For example, they may develop an attribution model that assigns patients of certain types to organizations with certain capabilities. For example, a high-risk population may get assigned to one organization, whereas a low-risk population may get assigned to another. Another example is that in some models, payers will opt to try to assign an entire family to a particular provider or provider group, whereas in other models they may use certain utilization markers. So patients who utilize hospital services, they may wish to go to a different organization than others. We'll talk a little bit too about how patient choice factors into that, particularly in the public insurance programs of Medicaid and Medicare. But we are seeing the payers kind of push the envelopes even in programs that have kind of unlimited patient choice. Most models are inclusive of kind of a specific duration or time span, and what we mean by that is that they look at a patient's utilization or needs over a given time period. So we don't look necessarily back at the unlimited, complete history of claims data going back for the entire patient's lifetime, but might instead look over the last year, over the last 3 years, in making determinations about where that patient should be assigned. Most and many, in fact, include some kind of geographic definition. Oftentimes this may be influenced by state law that says that a patient must be assigned to a provider that's reasonably accessible to them, that does not prevent any undue hardship for them accessing that provider. Depending on what the payer's goal is, the attribution model may include evaluation and management codes only or all physician claims. And what we mean by that is they may look at the subset of CPT billing codes that are focused on kind of office visits and say that's a clear marker or a good predictor of which patients are which providers are interacting with these patients most intensely. Or they may look at other models that get to kind of the total amount of spend. For example, you may want to send or attribute the patient to a hospital system that has managed the overwhelming majority of the cost associated with a given population. So as you can see, there's a lot of kind of complexity and a lot of options or levers that payers can pull in terms of defining how they're going to attribute patients. And the last note is that different specialties have different patterns of care, and therefore might require different models. A lot of the work that's been done to date has really been driven by primary care, and we'll talk about some of those models. But as we see essentially the need to include kind of specialists and other types of care or other settings of care in attribution models, we'll see some evolution there. So we are at a point in our history where this is very much a moving target, but we can certainly start to speak to some of the best practices that are emerging and evolving. I want to talk about two distinct and important types of attribution models. One is the patient-based model, and the other is the episode-based model. A patient-based model is a model that assigns the cost of each patient to a provider, and it provides a mechanism for holding the provider accountable for the totality of care for that patient. And it's the model that is most oftenly attributed or assigned to an ACO. ACO contracts, and we're going to look at the Medicare Shared Savings Program, which is the most well-known ACO contract. They really want to look at the totality of care, all of the claims paid for a patient, not just those paid for a certain episode or a certain illness for that population. And that sets the differentiation to episode-based models, which assign a specific episode to a provider. An episode represents all of the clinical services for one patient from the onset of symptoms through the completion of treatment, and it holds a provider accountable for that episode, but maybe not things that occur outside of that. For a chronic disease such as diabetes, the episode may be defined as treatment for a year rather than a discrete episode of care. We sometimes call that a bundle. A time-based bundle. But these episode-based models are important to understand as distinct from patient-based models because they typically revolve just around a certain set of services. So, for example, you might have an episode-based attribution model that attributes a patient to a hospital system when at the time they get admitted for congestive heart failure, and may hold them financially accountable for that patient for the 90 days following their discharge, all costs associated with that population. But if 4 months later that patient has a diabetes-related episode, they wouldn't necessarily be held accountable for that because the attribution model would not have taken into account what happens either 90 days later or for a different disease. And that's an important distinction to understand because we're going to see a lot of models that drive attribution based on propensity or majority of primary care type services delivered, and those are much more appropriate for organizations that do a fair amount of primary or kind of related specialty care versus hospital-centric models that will be much more focused on the episodic type of attribution. So just a couple of differentiators, and I think we kind of covered this in the discussion, but a patient-based model aligns the cost of a patient's total care to an individual provider or organization, whereas an episode assigns the cost of a specific well-defined episode of care. The patient-based models encompasses the entire spectrum of care, so it's really defined as within the contract, essentially any of the services that a patient might receive, regardless of the reason why they're receiving them, and it's usually made to a primary care provider. Those are not the case with episode-based attribution models, whereas both patient-based and episode-based the assignment may be made to both primary care and/or specialty providers, and in many cases, the patient may seek care from whoever they want. That's going to depend on essentially patient choice and the type of insurance product that the patient is enrolled with. Another set of distinctions within different attribution models is the prospective versus retrospective models, and we're going to define the difference between these two. Prospective attribution uses historical claims to identify the patients included in a provider's roster prior to the start of a defined evaluation period. An evaluation period typically lasting, although not always, 12 months. Prospective attribution is used in full risk and or prepayment arrangements, or where there is intent to drive change in the individual patient care and operations. So the reason why prospective models are important is if you wish to do something like a shared savings program where you are essentially paying or setting a target for a given time period, typically a year, and you need to reach agreement between the payer and the provider that benchmark, that cost benchmark, is valid and fair and is based on a defined set of patients. You can't essentially strive for improvement against a benchmark unless you know what the benchmark is and the underlying patients. In this model, patients don't choose essentially who they're attributed to. They are assigned, and then they're typically notified. For example, the Medicare Shared Savings Program requires the patient be notified, although the notification rules actually did change a little bit in 2017. The model is somewhat advantaged because cost and quality reports become readily available. You can start sharing data on the precise population essentially immediately upon reaching agreement on the contract. And since providers know who their patients are, it allows for kind of the most proactive patient engagement and activation strategies, as we'll discuss a little bit later. Retrospective is a model that is also assigns patients based on claims, but it's done at the end of the period, and its measurement ensures that the patient is attributed based on actual utilization. So let me just give you kind of a sense of a scenario that might give you a sense of why some plans or payers would favor a retrospective model. Let's say that a patient has had a relationship with a provider for a very long time and suddenly shifts and begins seeing a different provider. And it turns out that they achieve either really good or really poor outcomes over the course of that year. A retrospective model says, look, it wouldn't be fair to associate either the good or bad outcome to a provider they didn't end up seeing once within that year. Retrospective attribution is most commonly used in kind of population measurement and total cost of care contracts, where the results are typically updated on an ongoing cycle throughout the year. So attribution might change periodically throughout the year. Patients might pop on and off of the roster. For example, the measures may refresh quarterly and demonstrate a different set of underlying patients within that model. It limits really kind of the provider's ability to have access to real-time reports. It's also quite a bit more challenging to manage time to time, but it is considered more fair in terms of it's based on the actual patients that ultimately did come in and were seen. So just a little bit of comparison. In a prospective model assigns for a future period based on past utilization, whereas a retrospective model assigns responsibility for a past period based on actual usage. A prospective model uses quality and cost metrics reported throughout the year, so you can actually see kind of a running total, whereas a retrospective model would kind of look backwards and say, here's at the end of the year, here's who we can tell you saw, and here was the resulting costs for those models. And again, in most instances where there's a patient choice law involved, they can still seek care from any provider. So we don't have tools that say we can limit essentially who they utilize. So total cost of care will include calculations of costs driven by providers that don't factor into either a prospective or retrospective model. There's also a distinction between single attribution, which is when an assignment of a patient is to one and only one provider. And this provider is the one that was responsible for a majority of service costs. And some believe that this makes a single provider more concerned with the overall health of the patient. So if your organization is feeling, and it would be very natural in this environment to feel, a need to develop a new or a more robust kind of care coordination or population health management capability, it's because of this it's because of this single attribution type concept that exists in a lot of value-based reimbursement models. On the flip side, the concept of multiple attribution is one in which a patient is assigned to more than one provider across a spectrum. And the goal of this type of attribution would be to drive more coordination across a group of individual providers. So you can imagine in kind of a bundled payment or an episodic payment model that there might be an attribution made to a primary care physician, a cardiologist, and a surgical center. And together those three would be, all three of them would be on the hook financially. All three of them would be named essentially in a contract, and it would be up to all three of them to coordinate that patient through essentially that bundle or episode of care. In a single attribution model, responsibility is assigned to the provider with the highest amount of services or number of services or cost, and we'll look specifically at how that might work. Whereas in a multiple attribution model, it's typically a patient is assigned to multiple providers based on a historical look at services provided, may also take into consideration things like the geographic area and unique relationships that the health plan has in that geographic market. Single attribution is thought to drive more individual provider accountability for coordinating care, whereas multiple attribution is thought to force, kind of a team approach to that accountability. And as we've said in the others, patients do still usually have the right to seek care outside of that attribution. So a patient might get attributed to it. It doesn't mean that they're forced essentially to stay within that individual provider or care team. We want to look at now the concept of majority versus plurality of care. And as we look at different attribution models in this educational forum, we're going to talk about different types of models that are based on either majority or plurality. In a majority-based model, for example, a patient may only be assigned to an organization or to a provider if more than 50% of their care or costs reside within that system. That's typically used when assigning to a health system that provides a broad spectrum of services. And we can say, okay, if more than 50% of a patient's care is provided at a particular health organization, health system, then clearly that health system has the biggest opportunity to work on cost and quality for that patient. Plurality is used quite a bit in primary care-driven models, of course, and it's about the assignment of a patient to the provider with the largest proportion, whether or not that is more than 50% of both care and cost. And so there's kind of a subtle difference there, but we think it's one that's important, especially within the safety net, where we may not be delivering essentially the majority of care to many of our patients, but still may be seen under a plurality of care type model to be the one that's most likely to be able to affect cost and outcomes for that assigned patient. I've talked about this quite a bit, and I wanted to make sure I kind of drove home the point about the role of patient or consumer choice. As we may have experienced in our own personal lives, insurance products will often attempt to restrict our choice within a network of providers. And we are probably familiar with concepts like HMOs and PPOs that have different rules for how much gets paid on behalf of our care if we use an in-network versus out-of-network provider. And there may be scenarios where some providers are so far out of network that the insurance company is unwilling to pay anything for their care, and we are left as the patient fully responsible for any charges that we incur. Because of the way that public insurance works, specifically Medicare or Medicaid, patients have a lot more choice under those models. Medicaid throughout the country really kind of relies on an any willing provider model, which says that any provider who's willing to accept the state's payment levels for the services that they provide are fair game. They're providers that the patients are eligible to utilize. This is done largely for two reasons. Reason number one is that Medicaid often has challenges getting access to certain provider types, so they aren't necessarily willing to restrict, particularly in specialty care, who a patient can see. It's also typically resides or derived from the fact that government-sponsored insurance is considered to be a large government procurement program, and restriction of networks could be, seen as unfairly allowing for providers to participate in that model. So in most of the attribution models that we will face as safety net providers, the patients may be assigned to a provider or a provider organization. That doesn't necessarily mean we have any tools to force them to use that provider. So when we talk later about engagement and activation strategies, we actually need to come up with some ways to get them kind of change or modify their behavior to use appropriate settings of care. For anyone that's attempted to steer a population of patients away from emergency departments for ambulatory sensitive conditions, you know how challenging that can be. Lastly, I want to say that even though there are patient choice laws that impact a lot of this, Medicaid managed care organizations in particular are still allowed to develop auto assignment or for preferred attribution models, which means they can essentially not require but suggest strongly that a patient seek care from a certain provider or attribute that patient to a certain provider. And so, depending on where you are in your discussion with those who pay you, one of the negotiation points that we think often gets missed, negotiations tend to revolve very much around setting rates, but one of the important points that does sometimes get missed is you can also negotiate on how patients are ultimately assigned or attributed to you under various payment models. I'm going to stop real quick. I want to open up the line and see if anyone does have any questions. We've got a lot more information, but we have just given you quite a bit of information. And I'm going to just pause for 1 second and see if anyone has any questions or comments they want to make. Okay, well, not hearing any, I'm going to continue. There are a set of useful data sources that you will find that get factored into these attribution models. The most important of which is historical claims data. And this, claims data is ultimately used to look at historic patterns of utilization, historic patterns of cost. It's also used to kind of derive the next two, which are total cost of care and total cost of care by bundle. So total cost of care would be a more inclusive topic, one that would look really across the full set of benefits that a patient is eligible for and received. Total cost of care by bundle would look more narrowly at the total cost of the care that a patient received for a specific set of services within a specific time window. These are important to understand because, as we'll see in a second, we're going to talk about a shared savings program that's self-benchmarking, which means that it looks at the costs for a population of patients for a group of providers that have already seen those patients historically, that have a relationship with them. And so in those type of models, we're performing or trying to beat ourselves from previous periods for the same population of patients. Total cost of care, of course, is something that the payers can calculate, not necessarily something that we can calculate because we may have all the data that we build on the services we build, but we may not have all the data on all the services that were built elsewhere. We likely don't, in fact, have that data. Other data that is used is geographic and demographic data. For those of you that operate in high rural markets, how this might impact you is that you might receive an assignment simply because a patient is geographically, physically closest to your organization. If you operate in high urban markets, this can be a contentious topic, often having to have some set of kind of tiebreaker rules or fairness rules because the markets can be much more competitive, and we want to make sure that the plans are attributing based on an objective set of criteria that don't disproportionately hurt essentially growth in our panel size if we choose to grow. We use data around kind of performance years, or what we call periodicity. So we look at cycles of utilization in these types of reports. We also have to look at, or the plans have to look at, patients who may have received care periodically throughout the year, but who don't resolve as an assignment. And how might that work? Well, if they saw 2 physicians the precise number of times, and the attribution methodology does not have essentially a tiebreaker for how to make that assignment. And then kind of one of the untilled frontiers, one of the real areas of opportunity is those patients who are attributed or assigned but have not received services. And in this country, and as we have in various parts of the country, in various states, have expanded Medicaid, one of the real growth areas for our organizations has been in particular the male 18 through kind of 65 that otherwise had not been eligible for Medicaid, suddenly becoming eligible for Medicaid, may have a history of very low utilization. And now the fundamental question is what do we do with those patients? What can we do to keep them healthiest? How should we engage them? Certainly getting them in for care when they historically haven't used any will show an increase potentially in direct costs, but may really help us catch certain illnesses, conditions, avoidable complications that otherwise we wouldn't have had an opportunity to. So that's really kind of a double-edged sword, and how do we approach that? There is a question that's come in on the chat, which I'd like to take a quick moment to address. And the question is, are any of these models used simultaneously by payers? And so it's a fairly complex question to answer, because I can't say definitively that there's no such thing as a plan or a payer that is using more than one of these models. But what I would suggest to you is that in any one of these models, there really needs to be a level of kind of discrete assignment to an individual patient. So if a plan may be using multiple models, it can't be using multiple models for the same patient at the same time. So if they're going to create a model that's going to be based on a single provider assignment that's done retrospectively based on historical claims data and is based on a plurality of services type model, and they run that for a certain set of their patients and make those assignments, that should be the one and only model that is in use for that individual patient. Now, they may have different contract types that affect different populations, and that may start to be where you see kind of multiple attribution models for different subpopulations of their covered lives. But I think the important thing to understand is that attribution, just like compensation and type of payment model, attribution is something that you negotiate. It should be in the contracts that you sign when you enter into value-based reimbursement models. You need to clearly understand how it works and which patients it affects for that particular payer. And personally, I wouldn't accept a contract. I think your best defensive strategy here is I wouldn't accept a contract that either had a attribution model I didn't understand, had an attribution model that had discrepancy that could be become a point of contention in actually evaluating performance against that contract. And more often than not, in the organizations that we work with, it's a single attribution model for a single, payer, or certainly for a single payer contract. I hope I've answered that question. If I have not, please feel free to add to your question, and I'd be happy to readdress. Okay, really quickly, I want to take you through the Medicare Shared Savings Program attribution model. Some of you are in this program, so you have some experience potentially with how this works. But the Medicare Shared Savings Program is a program that requires a defined population of patients in order to calculate an expected total medical expense. And CMS has really honed this model, as I mentioned, over the last 7 or 8 years, as they've worked to improve the program. And at a high level, what they do is they look back over the course of time and try to predict what a population of patients is going to cost, and then offer some incentives if the provider signed up for the program can improve or come in essentially under those costs. First and foremost, and this is backed by some really sound actuarial research, CMS believes that a population of less than 5,000 patients loses actuarial integrity. Meaning, and what that means is that with less than 5,000 patients, it's really hard to, with a high level of confidence, determine that it is the provider that they've attributed a patient to that is actually impacting cost. There's too much randomness in what populations of patients can cost, that if you get below 5,000, it could be any number of random factors. Therefore, they require that an ACO have a minimum of 5,000 beneficiaries. And there are some Medicare patients that will not count in the attribution, and this, you know, and as a result, while our practice management system, for example, might tell us, oh, we've got 6,000 patients who we've seen last year that have Medicare as an insurance, we should be a shoo-in for this program. It's not quite that simple. So there's a variety of rules that make up the CMS attribution model. It's a self-benchmarking program, and what that means is that the prediction of future costs is based on the history of costs for the precise population of patients that will be attributed to the provider. And this is in contrast, for example, with another shared savings program that might base compensation or base cost comparisons on, say, a regional, state, or national average. This is particularly important for the safety net to understand because your population of patients might be fundamentally sicker, might have more acute social determinants of health, and as a result might have a very different cost profile. Or as a safety net provider, you might say, well, yeah, that's all well and good, but I have a history of kind of working to prevent utilization, emergency department, I've got a dental program that helps keep people out of the hospital, whatever it might be, and I don't want to be punished if my costs are really low. If you were using kind of a state or regional average, you might find that to have some kind of discrepancy or kind of unfairness both ways. Maybe it's unfair and provides us with too much opportunity, or maybe it's unfair because it doesn't take into consideration that our patients might have more risk factors. So CMS created a program that is what we call self-benchmarking. And it says, just very huge oversimplification, if an individual patient cost $150 last year, they're likely to cost somewhere around $150 this year. And then they apply a whole bunch of other rules to, to kind of modify that number. But that's generally speaking how it works. As a result, they have to demonstrate that the patient had a historical relationship with that provider. So actually what they do is they look back over 3 years before making a determination as to whether that patient, they can make a claim that each individual patient is in fact impacted in the past 3 years by that provider. And that sets up this scenario where you're essentially competing against your own historical performance in caring for that patient. And so what we like to say to our organizations that have entered into the Medicare Shared Savings Program, if you enter this program for the population of patients that you've seen for the past 3 years, improving cost and quality likely means doing something fundamentally different. You can't just go into next year doing the same old thing and expect to have a major impact on care. I mentioned the program uses a 3-year look back. So what it does is it takes all paid claims for the population of patients served by the organization applying to be in the program, and literally pulls every Medicare Part A and B claim that was paid. The determinations are made in the attribution process are evaluated based on what's in that data. And so the ACO itself has virtually no control and little visibility into that process. So while there are some things that an ACO can do to predict that it will have more than 5,000 patients, it's based on whether they billed historically well accurately, 3 years ago. And factors like provider turnover, factors like patient turnover can really negatively impact. So like I said, if just because your practice management system says you had 6,000 patients last year does not mean that you're going to get 6,000 patients assigned. So the more that you know about how the attribution model works, the better off you are in terms of being able to predict what your attribution will be. Then they apply this two-step model, and the two-step model really tries to determine where the patient received a plurality of their primary care services. If the provider who is applying, or the group of providers who are applying for the program provided the plurality, which doesn't have to be more than 50%, it just needs to be the largest of all the providers who provided services to that patient, they're likely to be assigned to that provider. The rationale is that if a patient receives the plurality of his or her services from a given organization, that's the organization that has the best ability to influence things like total cost of care. The two-step process basically says you make a first cut, the first step, which is patients who clearly have one provider who makes up a plurality of their services. If that happens to be the applying the provider, then you just make that assignment. If it isn't clear, then you default to a second step, which looks more granularly at certain other factors for that patient. The first step, as I mentioned, is easy. If there's only one primary care provider over the past 3 years in the claims data, make the assignment. If not, they actually look at things like specialist claims, specialist billing, E&M codes in making that determination. Okay, I think there's a question. The question is, what does MSSP mean? I apologize. That stands for Medicare Shared Savings Program. It's commonly referred to as the ACO program. It's the program that basically instantiated the accountable care organization term in our kind of lexicon, but CMS refers to it as the CMS Medicare Shared Savings Program for Accountable Care Organizations, and we have chosen to abbreviate that as MSSP. So takeaways from the Medicare Shared Savings Program. Many models, this one in particular, are linked to primary care service utilization, not all. And certainly we know that the organizations represented on this call are not all primary care providers. But under this program, it is critical to have an adequate number of these types of providers. Your organization may face the same issue when identifying providers to participate in payer contracts. What we have found is that many safety net organizations need to partner or work together to operate under these types of programs. It's not essentially possible to enter into some of these programs without partnering with other organizations. Some of us are just frankly too small. And that lesson from the idea that understanding the payment methodology might help us understand who needs to be involved in a particular type of contract, I think, is an important one. So as we look at different models throughout the next couple of weeks together, we want to talk specifically about how that impacts the organizations that are represented on this call. I'm going to move ahead into defining patient attribution and activation. And we're going to spend a little bit less time here because this will be a topic that we pick up again in the 4th and 5th weeks of the presentation. But we wanted to leave you with a definition. Patient activation is defined as a set of specific strategies and activities that engage attributed patients in order to involve them in their ongoing role in the care process and assuring that they have the knowledge, skill, and confidence to actively participate in their care with their provider team. I really like talking about the opportunity that Medicaid expansion afforded for those of us in a Medicaid expansion state to really, for the first time, engage the male 18 to 65 population that historically did not proactively seek care, because I think it gives a good example of what activation requires of us. It's about finding patients who may not understand how best to engage in their own wellness and educating them, getting them engaged with their provider. Many of the concepts that I think we've come to know as the patient-centered medical home. And so as much as anything, this is about having a strategy for dealing with that list of patients that gets dumped on us from time to time by those who pay us, who we don't have a really good established working history. Patient activation is similar but not the same as patient engagement, but it places a specific emphasis on being able to demonstrate and measure the patient's meaningful participation in their own health care. Best practices in patient engagement can assist with inpatient engagement, can, however, assist with effective patient activation. So whereas patient engagement might deal with strategies for even basically just reaching out and communicating, patient activation is about behavior modification and change that essentially creates a desire on the patient's behalf to seek wellness, to seek care in a efficient and effective manner. And so here are a couple of examples, and as I mentioned, in the later weeks of the Learning Collaborative, we're going to get into more details on these. But an activated patient might be more likely to participate in the development of their own care plan. And this, particularly in chronic disease management, as we know, is actually a pretty good indicator of whether they're going to be successful in achieving a desired level of wellness. A patient that actively chooses to make lifestyle modifications to diet or exercise or smoking are more likely to actually execute those than one who simply receive a prescription from a provider to eat better, exercise, or quit smoking. Another example would be a care manager making follow-up appointments on the spot with a patient and then helping to coordinate or navigate that patient to make sure that they keep those. And many of you, I'm sure, have programs like this to assist patients in navigating what can be a very intimidating and sometimes confusing healthcare landscape. Another example might be effective training and use of remote monitoring tools. So in what you will come to learn as one of my favorite examples, a congestive heart failure patient that is discharged from the hospital who is routinely followed up on by a care coordinator and can effectively communicate weight loss or gain over the first several days of receiving care, after receiving essentially care in the hospital, are much less likely to end up back in the hospital. However, one of the barriers is simply educating them that they play a role in communicating their ongoing weight to their provider. And lastly, the centralized coordination of outreach for annual well visits. And what you'll find and what we'll discuss is that plans under the Affordable Care Act, and we hope that this continues, although there's a lot of uncertainty, have created some financial incentives for patients to seek annual wellness care by essentially making it, free is not really the right word, but included, often without copay or cost share. That behooves us as providers to find ways to get patients to take advantage of that opportunity so that we can avoid some of the unintended consequences. We have another question that's come in, and I wanted to address it. Is patient engagement based on UDS data, patient self-report, or claims data? The answer is there are likely models that might look at all three, although I don't know any that look specifically at UDS data. The most common models that we see are driven off of payer claims data for two reasons. Number one is because that is a more complete picture of what the patient has used throughout the course of time, whereas UDS data is not UDS data, and for those that aren't aware, UDS is a type of reporting that federally qualified health centers do about who their patient populations are. So claims data, the first reason why it's more commonly used is it's much more comprehensive in looking at the total set of things that the patients have utilized. The second reason why claims data is more commonly utilized is because payers tend to trust it. I know that we have some issues as providers. We tend to have some issues in trusting them when they say to trust claims data, but they do tend to trust that as a much more accurate or complete picture of the truth. Where does patient self-report come in? And again, this can vary by attribution model, but patients can and sometimes do opt out of the attribution assignment that has been made for them. This is not so in the case of the Medicare Shared Savings Program we discussed. In the Medicare Shared Savings Program, patients do not have the choice anymore, I don't believe, to opt out of the attribution, but they do have the choice to see whatever provider they want. So they're not limited in terms of their behavior, but they can't undo the assignment to a provider. They can choose not to see that provider, and that could have negative consequences for that provider trying to manage their care, but they can't undo that assignment. But in some contracts, they actually can. They can say, I don't want to be involved in this program. Please take me out of that program. As I mentioned, I have not seen anyone use UDS data. I certainly have seen groups negotiate that the attribution methodology will be verified by things like practice management system data. So we've sometimes helped groups negotiate clauses that say that attribution won't simply be assigned. Attribution will be negotiated after the contract is signed based on essentially doing an analysis of practice management data, essentially creating an appeal process and therefore a way for the provider to say, in fact, this patient is a historical patient of ours and we think should be included in our attribution. So I think the important take-home message is not all attribution models are created the same. We need to understand them as we shore up our contracts or as we enter into our contracts. The contract can't really be silent on it because it's so critically important to understanding how many patients we're going to end up with and how we're going to interact with those patients. And we really can and should negotiate those terms to make sure we clearly understand them and do whatever is best for our organization in entering into those contracts. I'm going to get back now to patient activation. So in measuring and evaluating patient activation and engagement, evidence strongly points to activation improving quality. The evidence there, on cost is a little fuzzier, but it still demonstrates some of and we believe that the impact on quality will ultimately resolve in a savings in cost. But we're going to talk about activation strategies later much later in the learnings, and we'll talk about some of the types of measures of patient activation and how they are seen as linking essentially to quality. I would ask you though to think about even just in your own lives or certainly in your work within a provider organization. I think you fundamentally know the difference between a patient who's kind of activated and excited about embarking on a weight loss program or a healthy eating program or better management of their diabetes versus a patient who may not be quite as activated, may not see the connection between potentially living a healthier and more satisfying existence and essentially better self-care. And certainly, I think it's very rational to believe that a better activated or a more activated patient is more likely to improve their outcomes. Your organization can identify measures to track patient activation. Most of these are process measures, such as did the patient come in for an annual wellness visit, were they involved in their care planning, but there are some tools such as the CAP survey and the patient activation measures survey, which we've provided some links for, that can in fact actually start to more objectively measure in a standardized fashion these types of levels of activation. I want to make the point. I think it's a point worth making at this point in the education that some of the most successful care coordination initiatives actually use a measure of patient activation to allocate resources. And this might be a topic that we'll want to have a little more discussion on as we go, because it can be a little counterintuitive and even potentially controversial. But the idea is that applying resources to an activated patient might make more sense than to a deactivated patient because you're likely to improve more rapidly with that population. The counter argument would be, well, if the deactivated patient is at a higher risk, then shouldn't we put more resources there? One of the things we think is going to evolve as, and be kind of one of the leading areas of research and interest in this field is differentiated strategies based on different levels of activation. So instead of saying apply all of your resources necessarily only to those that are activated, you might say apply your care coordination resources to the activated population and apply your activation, have a whole separate set of different activation tools to your deactivated population ahead of applying care coordination resources to them. We'll talk and we'll kind of debate that together over the course of time. Okay, at this point, I'm going to ask AJ if he can bring up. We have you have 2 assignments this week. This is the first one, and it's just a set of homework questions. You're going to get a survey link via email. It's also available in the presenter notes section of your screen right now. And we'd like you to answer these questions. When you click on the survey, you'll find these questions. You'll be able to provide us with some input. We don't believe this will take very long to go through with your team. And it gives us some immediate opportunities to engage you folks in discussion the next time that we meet. Don't spend more than, we don't believe, 15 minutes to a half an hour with your group discussing these and then getting them entered into the system. That's your first assignment before the next time we meet. The second assignment before the next time we meet is for you to read a set of case studies. And again, we don't think this is going to take you very long. Are we able to bring that up? Oh, okay.
I'll send it to them.
Okay, you're going to receive the case study documents via email. Will that be later today, AJ?
Yeah.
Okay, later today. And again, we don't think that it's not intended to give you a lot of extra work. We know that you folks all work a day job. But what it does provide you with is 3 separate scenarios under which you would evaluate 3 separate, essentially, lists or data sources that would define a patient attribution model. The 3 data sets that you're going to receive, and they're not massive data sets, but they represent very real scenarios that provider organizations such as your own might receive from plans as you are either negotiating or managing a value-based contract. The first data set is a set of sample reports that are based upon the actual reports that Medicare sends its ACO participating organizations. So those of you that are in the ACO program, the Medicare Shared Savings Program, have probably already seen these. The second set of data is a detailed monthly patient roster, and it's adapted from an actual statewide Medicaid value-based payment program. Essentially, it provides information on the patients assigned to an organization. We're asking you to assume that that was your organization and to think through some of the opportunities and challenges that it presents. And the third data set is a small snippet of detailed claims data. So it's going to show you the detail, including what was billed, how much it cost, what was paid, and we have a set of questions for you to think through as to what type of analysis might you wish to engage in as it related to better understanding your attributed population. Again, we'd like you to spend some time on this. We've provided some discussion questions. The discussion questions we will be essentially walking through. Our entire next session essentially will be focused on breaking down the case study that you're going to receive by email. So it's really pretty important that you give it at least an hour of your time to really think through, and we think that it's going to be a really valuable exercise that's going to prepare you not only to have a more meaningful discussion over the course of the next 5 sessions, but also for what might be coming or already present in your own organization as it discovers and explores value-based reimbursement options. I'm going to, with that, I'm going to turn it to you folks. I do want to make sure you understand that we are more than happy to answer questions and assist you in kind of your learning throughout the course of the next 6 weeks. You have our email addresses. Please feel free to send us any questions. You've also been receiving information from AJ here at the university. He's another resource that you can tap into, but certainly for anything content related, by all means, feel free to reach out directly to us. And with that, I would like to turn to you folks and ask if there's any questions you have, any comments you want to make, any feedback you want to give us now before we let you go. The lines are open, so feel free to just speak up if you have questions or comments.
Hello?
Yes.
Yes, this is Teodoro Anderson Diaz calling from, actually speaking from First Choice Health Centers.
Yes, how are you?
Thank you. I'm doing great. Thank you so much for the presentation. It was quite informative.
Good.
I'm wondering, what is the actual research as it relates to improve health outcomes by using these attribution models? Is it more driven by improving health outcomes, or is it more driven by lowering the cost?
So that's gonna, yeah. So the research is, I don't want to say sparse, but this is a fairly new approach to to this type of work. We could certainly go back and look at the HMO initiative 30 years ago, 40 years ago. We kind of know what some of the failings of that are. So the body of research that suggests that attribution-driven value-based payment models are a good idea are all fairly new. Basically within the last six years or so. Just to give you an example, the Medicare Shared Savings Program, which we will discuss in detail because it's the most widely available and also the most, we believe, the most well thought out of these programs, has been in place for approximately 6 years. It takes 2 years just to get some results because you have to run a full year's claim cycle to calculate your results, and then it takes almost another 6 months to even determine the impact of the results themselves. So it's only been about 3 or 4 years that we've even been able to look at which groups of providers have been effective in actually driving quality and cost outcomes. That program is slightly heavily more weighted on the cost as a driver of success than the quality and outcomes as a driver of success. What I would say is that it tends to use cost as the mechanism for determining the size of the bonuses paid to providers, and quality as essentially a measure of really to make sure that they didn't hurt the population. So what we learned during the HMO days was the easiest way to drive down cost was to severely restrict access. If you severely restrict access, you can almost 100% of the time you can improve cost. And that led to a lot of bad outcomes, and then what turned into higher costs later. So the Medicare program says you have to save money, and if you save money, we'll share that money with you. But if you save money and quality goes down, we're not going to give you that money. So we would say that it really encourages, and when we coach groups that are entering that program, we say you need strategies that first look at cost. And then second, you need to make sure that those strategies that improve cost don't hurt quality. Here's what we've found, and I'll try to track down probably the most comprehensive assessment of the programs, of the several hundred. There are actually about 500 organizations that participate in that demonstration. Here's what we found. There is definite research to suggest that organizations that essentially implement fairly aggressive care coordination approaches are very successful in both reducing cost and improving outcomes. That said, there's a wide variation in the results that have been achieved by various organizations in doing so. A small percentage, I want to say something like 12%. I'm going off the top of my head here. I don't have the article in front of me. actually drove up costs. A much larger percentage stayed essentially within the what's known as the minimum savings rate, which means they didn't save enough money to trigger essentially a bonus. And then a decent sized percentage, about half, generated some real savings by better coordinating and managing the care of their attributed patient population. But the factors, and the article kind of goes into some of the factors that led to those findings. The factors really had to do with taking this attribution stuff seriously, understanding who the population of patients was, and as I kind of gave that cautionary message earlier in the presentation, doing something fundamentally different. It doesn't matter if you're the best provider in the universe. If you're competing against your performance in a previous period and you don't do something different, you shouldn't expect a different outcome. So without getting in, and without certainly misrepresenting the analysis, I think the keys to success were quickly, identifying within the source systems, the EHRs and the practice management systems, that attributed population, getting to know, particularly for some of the higher cost or higher risk patients, what the drivers of cost were, and then systematically developing clinical programming and care coordination supports for those patients that addressed those drivers of cost were kind of the keys, the overall keys to success. Put another way, I think one of the most compelling things that I've read about these types of programs is the organizations that try to take on 100 new behaviors for addressing the needs of the population they serve are destined to fail, whereas the groups that pick 3 to 5 important strategies that address important underlying subpopulations really tend to be the ones that have had the most success. And that was actually a learning that came directly out of a kind of a Medicare-sponsored recap call with some of the highest performing ACOs. So I think we'll have more to come on that. I will dig up some specific information, but we're going to be exploring that very question together. I hope I've given you at least a partial answer to your question, and we'll be exploring that together.
Thank you.
Yep. Any other questions at this time?
Will you be sending that, trying to find, are you going to be actually sending the homework assignment sheet? I'm trying to find.
Yes. So you're going to receive an email that will include a link to the survey. The slide deck will be included in that. Okay, the slide deck will be included in that, as will the homework assignment, the case study that we'd like you to read going into next week. Or sorry, 2 weeks from now is when we actually will have our next session. Any other questions? Okay. Well, with that, I'd like to thank you for joining us for this first session. We're excited to have an opportunity to get to know you folks better. We will talk to you in 2 weeks when we will spend an hour and a half really digging into that case study. So please come prepared, and don't hesitate to reach out if you have questions or comments in the meantime. And with that, we will give you 15 minutes back to your day. Thank you.